Welcome to the VCU Department of Internal Medicine Grand Rounds. Today is a special Grand Rounds here. It's part of our CPC lecture series hosted by the chiefs for the Department of Internal Medicine. Just a couple of quick housekeeping items before I turn it over to our chief, Taylor Wood. Quick thing, this is the last session before the holidays, so we'll talk about that in 1 second, but there will not be any Grand Round series for the next 2 weeks. We will resume in the first week in January. More information to come on location and whether we can get some folks back in person. As always, the CME code should be posted in the chat box now and again towards the end. And also utilizing the chat box, the Q&A function, or raise your hand. We can get to your questions towards the end of the session, about 5 or 10 minutes. Again, thank you all so much. And I'm going to go ahead and turn it over to Taylor Wood to do the introductions for CPC, as well as our guest speaker, Dr. Casey Cable. So thank you all so much and happy holidays.
Awesome. Thank you so much. Definitely excited to be doing my CPC today. And one of the last Grand Rounds of the year, which is incredible. I remember when I was asked to be a chief, one of my first stresses, oddly enough, was doing the CPC, and here it is. First of all, before I get into the CPC, I do want to give a shout out to all of VCU as a whole for our Feed More donation. We've raised the total right now, $4,086, which I think is probably a record. I think the chiefs, whenever I was an intern, raised about 3,500. So the fact that we've crossed that threshold and smashed it is absolutely incredible. And for that reason, all of our chiefs, Dr. Syme, Dr. Forrest as well, is dressed up in holiday costumes on North 9 right now, serving pizza to residents. So, and I will be in my Grinch outfit after this is over, as was chosen for me. But excellent. So let me introduce our discussant for today, and then I'll get into a bit of the patient presentation. So today I'm honored to be introducing Dr. Casey Cable, Assistant Professor of Medicine here and Associate Director of Resource Intensivists within the Division of Pulmonary Disease and Critical Care Medicine. Dr. Cable grew up near the Kennedy Space Center in Central Florida, and she graduated from Tufts University with a Bachelor of Science in Chemistry and Biology. She went on to earn a master's degree in analytical chemistry while working on the NASA Phoenix Mars lander. Very impressive. She attended and graduated from the Florida State University College of Medicine, going on to complete her internal medicine residency at Mayo Clinic in Florida, and then a pulmonary and critical care fellowship at Emory University, while also earning a Master of Clinical Research with her thesis on lung protective ventilation and sepsis. She's actively involved in CHEST. She serves on numerous committees, and most recently was named the Clive Curran Fellow on the Guidelines Oversight Committee. We'll get to Dr. Cable in a moment once I introduce our patient for today. So let me change my screen share here 1 second. All righty. So again, welcome to Grand Rounds, our Clinicopathological conference. So we have Dr. Cable, myself, and then an expert at the very end that's currently a mystery that will reveal themselves when the time comes. So the format of this, introduction and case overview, I say 5 minutes. It's running between 5 to 10 minutes. I'll try and make it as fast as I can so you can still understand me. I've been told I talk fast, and that's something I've been working on. Thank you, Neha. But case discussion and dissection is 30 to 35 minutes. That's Dr. Cable. Our content expert discussion will be 10 to 15 minutes, which is currently a mystery individual. And then any Q&A, if there's time, would be 5 minutes. So objectives. Identify key components in the patient's presentation, what's relevant, both their history and exam, but also in labs and imaging. Generate a differential diagnosis, starting system-based, starting thoughtfully broad, and then narrowing down. Use evidence-based medicine to support diagnostic approach and use critical thinking throughout the process, but also enjoying the wonderment that is medicine and the journey of learning. Not so much arriving at the correct diagnosis, but stopping to smell the roses along the way. And hopefully we can do that today. So getting into the case presentation itself. So this patient is a 46-year-old female with a past medical history of a hemorrhagic stroke, multiple sclerosis, hypertension, angioedema, and seizure disorder. And she presents with 4 weeks of progressive dyspnea and productive cough and white sputum. It's progressed to the point of being unable to ambulate a block without stopping to catch her breath. She denied any orthopnea or PND. At the same time, she reports 2 weeks of a pruritic maculopapular rash involving the bilateral upper and lower extremities, as well as trunk. She denied any new exposures or medications. She also has had lip swelling over the last week, but no stridor. The last time she had this was roughly a year ago, which she contributed to lisinopril, and it also occurred in the past to aspirin, penicillin, pork products, and shellfish. Lastly, she reports intermittent fevers throughout the day and night for the last week, but denied any weight loss. There's no weakness. There's no recent travel or immobility. Some of her review of systems, for the sake of time, I'll show the pertinent positives, and you can assume that any others you can imagine are going to be negative. So the pertinent positives for this case are fevers, chills, and night sweats. Respiratory-wise, there's dyspnea on exertion and cough. Integument, she does have a rash involving the arms, legs, and trunk. An allergic, immunologic, there is medication and food allergies that she notes. I'll give it time just so you can see some of the relevant negatives. Okay. Now, some of her past histories. So the medical history I've mostly touched upon, but that hemorrhagic stroke from an episode of hypertensive emergency with resultant left-sided weakness. She has multiple sclerosis, hypertension, seizure disorder, and angioedema. Surgical history, just a tubal ligation many years ago. Family history, significant for a mother who has hypertension, a maternal cousin who has lupus, and there's no family history of cancer. Social history-wise, she denies any tobacco, illicit drug, or alcohol use. She has one lifelong sexual partner and uses condoms regularly. She denies having any pets in the home. She has been living in a homeless shelter for the past 4 to 6 months, and previously used to work in a factory packaging chapstick. Allergy-wise, she has angioedema to lisinopril, aspirin, penicillin, pork, and shellfish. Her exam. So vitals, she presents and she's afebrile. Her blood pressure is 165 over 119. Her heart rate is 102. Respiratory rate was 16. And she's sitting well on room air. And her BMI is roughly 18. In general, she's mildly ill-appearing, but not in any distress. Her head's atraumatic. Tympanic membranes are clear. There's no nasal polyps or oral ulcers. Her dentition is very poor. And she does note that she has upper and lower lip swelling that's very mild. Her pupils are equal, round, and reactive to light, accommodation bilaterally. There's no diplopia, and conjunctiva is pink. Lymph. So she has no lymphadenopathy other than the fact that she has bilateral left greater than right inguinal lymphadenopathy. It's non-tender and is mobile. Cardiac exam. She's tachycardic, but it's regular rhythm, normal S1 and S2. There's no murmurs, rubs, or gallops. She does have 2+ symmetric pulses, and she has no lower extremity edema. Lung-wise, she does have inspiratory rails in all of the lung fields, but it is lower lobe predominant. She has good airflow, no wheezing or rhonchi, and no increased work of breathing. Abdomen, it's relatively benign. Normal active bowel sounds, it's soft, it's non-tender, it's non-distended, and there's no hepatosplenomegaly that's present. Musculoskeletal-wise, she has upper and lower extremity joints with full range of motion. There are no deformities, no joint tenderness, synovitis, effusion, crepitus, warmth, or erythema. Her muscles are non-tender to palpation. Neuro-wise, her cranial nerves are intact. She's alert and oriented ×4. She does have 4 out of 5 left arm and left leg strength that's proximally and distally, but the normal right-sided strength. She has normal sensation. Reflexes are intact bilaterally. There's no tremor or clonus. Her gait is normal, and she has no dysmetria or dysdiadochokinesia. Skin-wise, she has a maculopapular rash with scattered areas of nodularity and excoriation on the upper and lower extremities and torso that spares the face, palms, and the soles. Psych-wise, denies delusions, hallucinations, SI, normal memory, insight, and judgment. Getting to her objective data now, her laboratory values. You can see her basic metabolic panel. There are really no disturbances there, so I'll move on. Her other electrolytes, you can see her MAG is a little bit low at 1.7, FOS is 2.5. Moving to her CBC, her white count is 13.5, hemoglobin is 11.9, and platelets are 370. The differential for that white count is 55.7% neutrophils, 16.1% lymphocytes, 3.2% monocytes, 23.6 eosinophils, and 1.3% basophils. Now to hepatic panel, total protein 6.6, albumin is 3.2, bili is 0.6, AST, ALT are 47 and 50 respectively, and alk phos is 153. Her INR is 1.1, troponin is undetectable, ESR and CRP are 8 and 1.2 respectively. Her HIV is negative. You can see the various hepatitis panel, quote unquote, down there. It's essentially non-reactive and she's non-immune to hepatitis. Her syphilis is non-reactive. Platelia is 0.05. Fungitel is 46. And then her ANA is negative at 1 to 80. And then her C-ANCA, P-ANCA, anti-myeloperoxidase, and anti-proteinase 3 antibody are all negative. More objective data. So her UA, it's yellow, clear. There's no protein, trace leuks, negative nitrites, negative blood, negative glucose, 1 RBC, 6 WBCs, and no bacteria. Her urine drug screen is negative. Respiratory pathogen panel is negative. Blood cultures ×2 or no growth. CT head shows no intracranial hemorrhage or mass. There's no large territory infarct. She does have hypodensities in the periventricular white matter, left caudate, and bilateral centrum semiovalle. She does have air fluid levels in the maxillary and sphenoid sinuses. CT chest without contrast. So there are widespread centrilobular micronodularity present throughout both lungs. It's predominantly in the peribronchial distribution and no lobes are spared. There are some areas that also appear to demonstrate tree and bud morphology. There's also hyperexpanded lungs and generalized bronchial wall thickening. And there's no typical features of chronic interstitial lung disease. Last, for her diagnostic, she did get a bronchoscopy for this CAT scan. Her posterior oropharynx had diffuse purulent exudate that at times partially occluded the pharynx. Her airways were diffusely hyperemic. She had subtle nodularity along much of her tracheobronchial surface. And now she also had a BAL as well. And so you can see that the BAL respiratory culture itself just grew mixed respiratory flora. She had fungal, nocardia, Legionella, AFB cultures were all without growth. You can see her cell count there. The platelia was 0.02. The cytology had no malignant cells, and she did get a biopsy of the affected rash. It showed spongiotic dermatitis with eosinophils and negative direct immunofluorescence. So with that being said, I will hand the rest of this over to Dr. Cable, who will take us through her thought process of this patient.
Thank you very much for that wonderful case introduction. Let me go ahead and share my screen so we can get started. There we go. Well, I want to thank all of the internal medicine chiefs for inviting me, as well as Christian for presenting this the end of the year's internal med CPC. It's always an honor to be selected, but also a little nerve-wracking. So I hope to do this discussion justice, kind of really walking through a thought process on hopefully where this case is going to go. There we go. So I've got no disclosures or conflicts of interest. Although I will disclose that some of this area that I'll be discussing is not my actual field of interest, but once again, I'll be very much curious to see what our expert case discussant has to say towards the end. If anyone does have any questions or comments, please, if you put them in the chat, I'll try to incorporate them. If not, we'll get to them at the end of the case. So going through kind of the review of the HPI and the reviewer system summarized, this is what I kind of captured from it. We have a 46-year-old female who has 4 weeks of progressive dyspnea and productive cough, 2 weeks of this pruritic maculopapular rash, and 1 week of lip swelling and intermittent fevers. With no medication, no new medications, no new exposures, no new travel, no weight loss, although I suppose I'll on the caveat would be hopefully no new weight gain as well, or weakness, as well as no orthopnea or PND. I thought it was interesting that it was noted that the last time, and yes, I'll use air quotes, that this occurred was 1 year prior. It was contributed to lisinopril and prior use with a bunch of other exposures, either aspirin, penicillins, pork, and shellfish. I'm not quite sure what the last time this actually references, if that's for the lip swelling and the fevers in conjunction with the rash, as well as the dyspnea, or is just as one of the 4 things. But either way, potentially this might be recurrent. I'm just going to highlight some things that stood out to me as red flags. So I'm going to highlight anything in red that's kind of a red flag to me of like, wait a second. So with her history of having, some autoimmune, kind of sequelae with having multiple sclerosis. And of course, angioedema has to stand out with her current lip swelling as well. With her social history, honestly, as being a pulmonologist, it's always nice to see somebody who does not smoke or inhale anything else into their lungs. No pets, hopefully no birds. But it does note that she is homeless with a shelter. So you kind of worry about if there's in different exposures along those lines. And then previously worked in a factory packaging chapstick. I hope she just packaged it. She wasn't involved in the actual manufacturing of any lipophilic type of things to be inhaled, but either way. So not much there. And with her medications, these hit some red flags as well. And we'll kind of touch upon some of these as we look at what some of her lab abnormalities are. We all know that amlodipine, it's well known that calcium channel blockers can cause angioedema. And so that has to be, mixed in the differential. As well as Keppra and kind of these disease modifying therapies for MS. Both of those medications on case reports have been known to also to cause eosinophilia. So once again, as we kind of move forward, these are some of the red flags as we're putting things together that kind of hit in my head of piecing together what might be going on. I just flagged all of her allergies. I'm sorry. They're all potentially causing, angioedema. Kind of unclear to what degree an angioedema was caused by, if there was any sort of anaphylaxis type of picture stridor, but either way, all of these are going to be red flagged. Tyler did a great job presenting the physical exam. I'm not going to be, berate any of these points, but things that kind of stood out to me were, she's a little hypertensive, slightly tachycardic, but her pulse ox, 92% on room air, is a little lower than you would expect from an otherwise 46-year-old. So that kind of stood out. We talked about the swollen lips, the kind of the lymphadenopathy inguinal, the rails, as well as this rash that she has ongoing. And moving on to laboratory testing, same thing that I know, that I kind of thought as well. Slightly anemic, WBC is 13.5. Otherwise, normal kidney function, I think that's something to note. Normal anion gap could be potentially useful in the future. And, kind of otherwise just maybe some mild electrolyte derangements, but otherwise normal. Hepatic panel, I'm going to highlight green. Green looks like it's okay. Hepatic panel is okay, as well as troponin, CSR, and CRP. But obviously, the elephant in the room is going to be her differential on her CBC, showing that 23.6% of eosinophils. Doing some quick math with her 13.5 WBCs, that provides us an absolute eosinophilic count of over 3,000 cells per microliters. So once again, I think that is definitely coming into gonna be interesting whenever we move forward. So. More laboratory testing, which I'm all highlighting as green as well. But once again, still very pertinent. Having a negative HIV moving forward, negative so-and-so hepatitis type panel, syphilis negative, the galactomannan and beta-D-glucan that the rest of the world knows. Also negative, negative an ANA at 1 to 80, but negative C-ANCA, P-ANCAs, the MPO, and as well as the PR3 antibodies. So I think those are going to come into discussion later as well. Pretty benign urinalysis, as well as, once again, not seeing a lot of glucose, or not seeing a lot of RBCs or anything of that nature. Drug screen being negative, respiratory and the glucose blood cultures being negative as well. So. Well, moving on to more of my realm, things I'm a little more comfortable with is going to be the BAL, which I also found very intriguing. Everything else being otherwise normal, aside from the elephant in the room, the eosinophils of 30%, markedly abnormal. So we do have, once again, eosinophilia in the BAL. The bronchoscopy noting kind of this purulent exudate, which I think will go along with the next slide that talks about her imaging, having some sinusitis kind of ongoing upstairs. And that was definitely noted, as well as kind of some nonspecific hyperemic, as well as kind of this nodularity along her tracheobronchial surfaces. I'm not going to get into some of those other disorders, but those red flags that kind of hit in my head when I started to form my differential. And as well as the biopsy having eosinophils on the biopsy, but negative for any direct immunofluorescence. So that was kind of a pertinent positive, I thought. And then last but not least, I just wanted to briefly talk about our imaging. And so my world again, CT chest, noted to have kind of this widespread central lobular kind of micronodularity in all throughout all lung zones. with a little bit of hyperexpanded lungs, maybe some bronchial wall thickening, but no features of any kind of chronic interstitial lung disease. Head CT, I only found remarkable really for kind of this air fluid, kind of a sinusitis type picture, air fluid levels in the maxillary and sphenoid sinuses. So with that, I wanted to actually, I can't give a CPC without actually showing a CT scan. So I want to give a special thanks to one of our pulmonary critical care fellows, Nuge, for helping to capture the CT scans. We'd actually go through it a little bit and just kind of see what some of these findings were. Okay, well, as we go through, there's a lot of motion artifact. I do have to, well, it's not really my fault, but I still will apologize. Lots of motion artifact as we move through. But what you can see is kind of in quite a few of these lung fields, even with kind of you can see some of the motion, you get kind of this central lobular kind of nodularity and pretty fairly diffuse. Every once in a while, you will kind of see a tree and bud, which is also not only that kind of central lobular nodularity, but kind of this kind of linear branching pattern that you can kind of every once in a while see. It's subtle, but it's definitely there in all fields. There is lots of motion artifact, as you can see with some of these kind of ghost imaging things, it looks almost like. But even getting down into here, kind of these small nodule, tiny little kind of nodularity that you can see, but no other large consolidations, no other significant ground glass for the most part. Once again, just kind of pointing out what some of, kind of visually what we can see. Now they do note a little bit of hyperexpansion on the lung. She does have a little bit generous lung volumes. Hard to say. I mean, she does have a BMI of 6. Oh, what's the next one? BMI of about 17. So she is fairly small. So once again, just want to show you guys kind of on the imaging things that I was looking at and things that I noticed, both for pertinent positive and pertinent negatives. So working through my differential thought process. So right now, the things that really stand out are she has this angioedema and urticaria. I mean, really honestly, with kind of the description of the itching and kind of this maculopapular rash, it really seems to be a more diagnostic of urticaria. Once again, along with kind of angioedema, some debate about those two concurring together. Can't disregard the eosinophilia, both in her peripheral blood, as well as the BAL, and noted in the skin biopsy. So I think those are my 3 things I'm going to focus on, and kind of wanted to go talking about each one of those 3 first and see what we can either exclude or include kind of as overlapping together. And some things out on the periphery that I still want to keep in the back of my head is she does have kind of a sinusitis picture. No really symptoms of that I've could find of asthma prior to this. And then this questionable, is this recurrent or not? It was noted that she did have a prior episode a year ago, and I'm not sure what that entailed. So, but still, I think that's going to be on the periphery as well. I think Michael LaRue did a wonderful job last CPC and really kind of discussing, are we talking about Occam's razor, Hickham's dictum? I mean, is this the simplest explanation kind of right through into here? Is that what's going to determine kind of what her diagnosis is? Or is it Hickham's dictum? Is it patients can have as many diseases as they wish, which that could be a little difficult, but I'm thinking more Occam's razor in this regard. So moving forward with that, let's kind of start to investigate a little more what we think in terms of each one of these 3. First thing I wanted to talk about is urticaria. And lucky for me, there is this great 2017 international guidelines on the definition, classification, and diagnosis and management of urticaria. All resources are down here if you guys wish. And so there's just a variety of different ways that urticaria can manifest. Mast cell driven, presenting with wheals, angioedema, or both. Now, this is the definition that all of these societies have come up with. So once again, they kind of give a little bit of an overlap with urticaria, but this is their definition. With their description of their lesions, circumscribed, raised, erythematous plaques, macular papular with itching. Acute urticaria is defined as being present for less than 6 weeks. So I think that is important. Now, she would be classified as having acute urticaria. And now she has a few other things going on. And interesting enough, this this paper actually, and well, I mean, and all their guidelines actually strongly recommend against any routine diagnostic measures in acute spontaneous urticaria, except for food allergies or other eliciting factors such as NSAIDs. However, in her case, she has other things going on. I think we're going to investigate further. And they do note that the lifetime presence for acute urticaria in all adults is about 20%. So it is fairly significant. So you will run across it. They give a wonderful description of the kind of walking through kind of workup of it. I think causes of urticaria, and thinking kind of general, the way I think about it, and this is kind of nicely laid out, is it IgE mediated, is it non-IgE mediated, or is it not even immuno-mediated? And kind of looking through this and kind of thinking into our subgroups of what our patient may have. We know that she's got food allergens based on her allergy history, as well as medications. Parasites, well, they base parasites based on, is typically based on history and travel history. Now, we do know that she is homeless. However, it's typically more travel to other endemic locations. So that may need to be further assessed. But we know that she also has potential autoimmune etiologies. Some of her fungals have come out negative. I don't know we have much history that we can attribute to any sort of malignancy lymphoma. We'll talk a little bit more of vasculitides. And then these are kind of the non-mediated. So I think we're somewhere in this realm. That review from 2017 that I talked about from all those various societies actually had a really great table, which I thought was very relevant to this case, because this really talked about diseases related to urticaria. Once again, not just isolated, and because I'm going kind of more with, I think there's probably an underlying theme for what's causing all of her symptoms, but I thought this was very interesting. So, they talk about kind of urticaria pigmentosa, which is more of a dark patchy type of skin disorder, probably not likely in her case. When they talk about urticaria vasculitides, those are much more painful, kind of ecchymotic and, kind of purpuric. So not likely in her case as well. So we're starting to cross some things off the list. When we get to talking about angioedema, I'll talk a little bit more about the bradykinin-mediated angioedema and why I don't think that is the etiology of what's going on with her. Not really exercise-induced, not getting a lot of those symptoms or signs. Going on, talking a little more, the different rashes, having any arthralgias, eye inflammation, so headaches. We don't have a lot of that ongoing here. This next syndrome is talking about kind of recurrent with this monoglomal gabinopathy, bone, muscle pain, arthralgias, things that she doesn't really have, and it doesn't really explain why we also have ongoing eosinophilia. We can come back to this, but kind of a poor test for any sort of increased, gabinopathies is, having a reduced anion gap, and hers is 10. So I don't know. So there's multiple reasons I'm going to cut that off the list. These two did kind of catch my eye. The last one is not characteristic of what she has. Oh, wrong one. But kind of this rare glitch syndrome, episodic angioedema, and Wells syndrome. I don't know if it's as much Wells. We'll get into why I don't think it's as much Wells later. Given that Wells is isolated eosinophilic cellulitis. It's just characterized by infiltration of eosinophils, so if you do have on the biopsy, but it kind of leaves out, some of our other pulmonary findings that are also important. So, but still, I think from this table and from that review, I think this is a very some interesting things that did come up. So getting back to kind of where we're heading with this, we talked about urticaria. Angioedema, very similar. It can be similar. So I think let's talk about some angioedema and rule some more things in or out of where we're headed. With angioedema, I'm really going to talk about the 3 different mechanisms, and I think that is going to help rule some things in and out. The first mechanism is going to be activation of mast cells. A lot of these include, food and drug reactions, which our patient does have. We talked about our aspirin allergy. And so I think, so those are, this is still definitely on the list of what could be going on. It is associated with kind of urticaria and itching, and those are definitely part of her symptoms. The second mechanism does not excite me as much, the bradykinin. So these are really, I know that she had a history of having a potential reaction to ACE inhibitors. Unclear what that timing and association proving really did, as well as kind of our hereditary angioedemas, either hereditary or acquired. But I think noting that these are not associated with itching or urticaria is important. So that's why I should have just taken a big X. I don't believe this is where we're heading. It doesn't explain, if we're trying to piece together everything that's going on with her. Yes, she has some lip swelling, but with her itching and her urticaria, as well as her eosinophilia, I'm going to take this off the differential for the time being. Which leads us to our the last mechanism, the everything else, the unknown category, which can include a variety of different things. Calcium channel blockers are on the list, drugs, also, as well as these classifications of eosinophilic syndrome, as well as that, glitch syndrome as well. So some of these kind of are recurring, which, whenever you start putting differentials together through all kind of your different boxes, if things start to cross over, things need to be considered and continue to be aware of. I think we talked about kind of why the vasculitis is I'm less excited about as well, given some of her symptoms. So with that, we talked about kind of urticaria and angioedema. Some overlaps are coming through. I'm really excited to talk about hypereosinophilia. I think that is, once again, kind of the elephant in the room, and gives a little more discussion about what's going on. So with that, with eosinophilia, absolute eosinophil count is greater than 500 for regular eosinophilia, run-of-the-mill. Then hypereosinophilia is classified as absolute eosinophil count greater than 1,500 per microliter. And if we remember what our patient had, doing the math, she had over 3,000. So she meets criteria for a hypereosinophilia. Now, when we think about peripheral eosinophilia and kind of associated diseases and disorders, this is a very small list. I did not list out everything. The Helminids could go on forever, same with the ectoparasites and the fungi. There is a whole host. I didn't even mention the drugs. So this table can get very small very quickly. But just thinking of the general areas, kind of the allergic area, the infectious, which I'm not sure everything was fully ruled out. Neoplastic is something that you also have to consider. The immunologic, general eosinophilic etiologies, as well as kind of miscellaneous. Some of these don't apply to her, some of them do, but I think to narrow down a little further, a great review, I have to plug CHEST, actually came out beginning of this year, which I thought was very fitting to help me, which was the approach to eosinophilia presenting with pulmonary symptoms. So once again, kind of very fitting for this. And this is a very, very nice review that kind of goes through in a very kind of systematic approach. I'm not going to present this, but I want this to be available to all of our trainees. Kind of a nice systematic approach to eosinophilia when there are pulmonary symptoms or involvement present. So I'll let you guys kind of chew on that later. But what they do have is a very nice differential diagnosis. And this is where I'm going to spend a little more time, because I think this is what is really kind of our culmination of what is brought. From here, we can really discuss what can be included, what can be excluded. Given what we have just learned about urticaria as well as angioedema. So when we talk about, so a few things I kind of wanted to talk about was, we talk about kind of the vasculitides, EGPA, otherwise known as Church-Strauss, definitely associated with sinusitis. So that definitely checks that box of, well, she has those symptoms. Multisystem vasculitis, their skin symptoms tend to be kind of more tender subcutaneous nodules, and when biopsied tend to show granuloma. So that's kind of a nix on what might be going on with that. Now, we know that her p-ANCA with NPO activity was negative, but only about 40 to 60% of patients with GPA tend to have that. So once again, not as exciting. And we talk about some of the other vasculitides, the GPA and MPA. These are vasculitis is affecting, for GPA, affecting the small to medium-sized vessels, as well as GPA's the capillaries. Still, you know, the ANCAs with the NPA and the NPO activities for either one, depending on if you have renal involvement, is variable. For GPA, ANCA positivity is seen in about 80% of the population. This is what I've looked up, as well as ANCA positivity for the NPO activity is about 90% in the NPA. But still, just because it's not positive doesn't mean you should completely rule it out. But she, you know, with normal kidney function thus far, not a lot of other with her other angioedema, as well as kind of her rash, if it doesn't fit these, I am not as excited about having these as of right now. When we don't have a pulmonary biopsy, they also don't look exactly like I would think about on the CT scan. And you know, I would think I would have a little more kind of infiltrative, kind of ground glass type of appearance, as opposed to this kind of central lobular micro nodularity. So either way, long discussion on why I don't think it's these things. We'll get back to hypereosinophilic syndromes. Those kind of interest me. Aspirin, you know, type of diseases, I imagine she's not taking any, so we're hopefully that is not the case. And she doesn't have a lot of asthmatic symptoms or Santer's triad, and no real noted of any kind of sinus polyps or nodules. For acute and chronic eosinophilic pneumonia, that's typically first on the differential. Anytime we do a bronchoscopy, get excited about elevated eosinophils. But acute is literally days to weeks, predominantly male, and cigarette smoke has been believed to be a causative role. So not likely acute eosinophilic pneumonia. Most of these patients are really sick, thick infiltrates on their CT scan, and about 70% of patients with AEP will need mechanical ventilation. She's not that sick. Chronic eosinophilic pneumonia, it's actually predominantly women age 30 to 60-ish, non-smokers. Usually asthma kind of precedes some of their symptoms. Once again, usually infiltrates, they look different than what we saw on her CT scan. And I don't know if I have a way to correlate her angioedema and her rash as well to that. So I'm not as worried about that. Incidence 2.5% in patients with ILD type. So not as excited about that. Anytime we get eosinophils, sometimes we worry about ABPA, which is kind of a hypersensitivity response to Aspergillus colonization. Typically on CAT scan, you see kind of thick mucus plugging, kind of the finger and glove is kind of the classic terminology that we think of, as well as an elevated IgE. And however, she did have a negative BAL for fungal testing. So for a variety of reasons, I don't feel like that is the cause. Now, parasites, potential. You know, she doesn't have any travel history of such. Although in literature, strongyloides is endemic pretty much everywhere. So potential stool and sputum testing with antibody testing with ELISA could make sure these are not what is going on. And when we talk about some other things, she is HIV negative, which is important. And then I kind of skipped over the drug induced as well. We know that she does have a seizure disorder. So she is on something that could potentially cause some of those potential eosinophils. Not quite sure if I can fully relate that to her other symptoms as well. One other thing that is not on this list, it's more pulmonary, but you know, I'm pulmonary. I've got to throw some things out there. As Loeffler syndrome, rare transient limiting pulmonary eosinophilia. But once again, don't believe that's the case. And then I think I did talk these hypereosinophilic syndromes. It was noted on both angioedema as well as urticaria. So I'm wondering if this might be where we're headed. It's associated with urticaria and angioedema. And by diagnostic criteria, and we can talk about this next, is going to be needing to have hypereosinophilia greater than the 1500 per microliter for more than 6 months. We only have one point in time with her for right now. And given that, this is a really nice kind of overlook at the various, and these are rare. So these are kind of very rare disorders, come in a variety of different variants. And these are to give you some examples of, some even more specific kind of identifiers and abnormalities you can find. And one that she may fit into a little bit more would be kind of this multisystem involvement. So it seems as though we have pulmonary involvement. We also have skin involvement as well. And it's really thought that a lot of these are due to kind of this eosinophilic infiltration into a variety of different organ systems. Mayo Clinic did a really good retrospective review, very small study, just based on the number of patients, but most of them presented with dyspnea, had some abnormal chest x-rays as well, some kind of various lymphadenopathy, and about 15% of patients with HES will have angioedema, and all of these subgroups can present with both urticaria and angioedema is what was determined. So I'm wondering if this is kind of what ties all of her symptoms together. Now, one thing I think I mentioned before that I do want to jump back onto and explain why I don't feel like we have glitch syndrome. I think that was mentioned in the very beginning. That's the episodic angioedema with eosinophilia, because that recurrence kind of still stuck in the back of my head. And this would be a crazy zebra, which is why we have a zebra smiling. Don't see it very often. This is really rare. It was first described in 1984, so fairly recent. Similar kind of to this aberrant T cell mechanism, and kind of a subtype of, if you go up here, this kind of lymphocytic variant of eosinophilia, based on these variety of variants. It is considered by episodic angioedema, urticaria, with itching, fevers, weight gain, which she doesn't have, and we don't know about her immunoglobulin levels. However, like I did note, she does have a normal anion gap, so maybe. And marked blood eosinophilia, which does parallel the disease activity. There's been some discussion about upregulation of the C5a receptor. That's a little more microbiology, lab biology if you're getting excited. It has been considered a type of hypereosinophilic syndrome. In reading the literature, there's still some debate about that, because most of it, there's an absence of kind of other organ involvement. And its episodic nature does make it different from these other kind of HES syndromes. And now, given that, I'm curious about the recurrence, but the fact that I think we do have pulmonary involvement as well as skin involvement, it makes me think less likely that this is what's causing her issues. But so that's why I'm going to go ahead and say I'm going to go with Occam's razor. I think the simplest explanation is usually the best. So looking at what could cause all three things together that we're looking at, I'm going to go with she has idiopathic hypereosinophilic syndrome. Final answer. Now with that is going to come, I wasn't quite sure where to go with diagnostic testing, because I think she needs to complete a full parasitic testing first. Once again, this is a diagnosis of exclusion, so she needs to have everything else removed. Second, I do think we need to remove some of those medications that are associated with either hypereosinophilia or as well as angioedema as much as possible. And then this is just for the scientist in me. In rare instances, when you kind of read about these HES syndromes, doing some mutation testing is helpful. This was only found in about 12% of patients in one study. There's some aberrant or clonal cell populations in about 20% of other patients, so we can consider that. Those are just kind of more going down the rarity list. Although having known the chiefs and their CPC, I would attest we probably do have some sort of a rare diagnostic conundrum. So I want to thank you. Hopefully this was useful and productive, kind of my thought process of rolling down kind of where things are going with what she had going on. If you have any questions, comments, concerns, please feel free to email me or find me on Twitter.
Hey. I think that was an amazing walkthrough of when eosinophils go bad. So I appreciate that. Your thought process was amazing. So I definitely learned a lot in this process. So thank you so much.
I did too. Some of this was out of my comfort zone, I have to say, but learned quite a bit down some of these paths.
Amazing. Well, I think it's time now to reveal our case expert. And that's someone that knows pretty well about what happens when eosinophils go bad. That's none other than our friendly neighborhood rheumatologist and assistant professor, Dr. Abhinandan. Welcome, sir.
Thank you, Taylor. Good to be here. All righty. Well done, Dr. Cable. Well done. Can you guys all hear me okay?
Just fine.
All right. So let us share the screen here. We're going to go screen one. All right. And you guys see the screen okay as well?
Yes.
All right. And we're still good. All right. Let me move this video down a little bit. You guys don't see yourselves, right? No. Okay. All right. Well, thank you again for do you see your videos on there or no? It's okay.
It looks perfect.
Looks good. Okay. So thank you again for having me. I appreciate the opportunity to talk about this case with you guys. So yeah, so this is the stupendously bearded Paul Erlich. He was actually the first one to describe what's been central to so many parts of this case, the eosinophil. And Erlichiosis, I presume, is named after him. But he also described a lot of other myelocytes along with eosinophils in 1908 very distinctly and clearly. Interesting fact about eosinophils, you know, they stain with eosin. That's how they get their namesake. And these are actually derived from coal tar dyes. And back in the day, they used to actually use these dyes to stain fabrics. And the early pathologists, you know, used these dyes to stain eosinophils and other myelocytes, and certainly it worked. And so that's how a lot of these ended up getting their name. Of course, we're going to have to start with a central talk on the pathophysiology of the eosinophil. And the thing that probably stains with the eosin dye the most are these granules, which are vastly actually probably underrepresented in this cartoon. Eosinophils are filled with hundreds and thousands, if not millions, of these granules. And these granules contain a number of proteins and chemokines. The eosinophilic cationic protein, the major basic protein, as well as cytokines. So the major basic protein, for example, it's highly potent against helminths, but in allergic disease, it's also been implicated in bronchospasm. In lipid bodies, which are also present in eosinophils, have been contain leukotrienes, which have been associated in bronchospastic disease. And then in terms of the cytokines, the granules themselves also contain some pro-inflammatory cytokines like interleukin-6, some self-regulating or immunosuppressive cytokines like interleukin-10, as well as TGF-alpha and TGF-beta. And these can lead to a variety of different pathologic manifestations. So for example, the EGPs can lead to allergic inflammation. Major basic protein has been known to have some pro-thrombotic effects, and TGF-beta can lead to fibrosis. So let's take a step back now and think about, you know, how eosinophils really come to be. And remember that eosinophils are myeloblasts, which come from a common myeloid progenitor, which essentially derive from hematopoietic stem cells. And what is critical to their maturation and to their development is interleukin-5. Okay, I want you to walk away with interleukin-5 as an important point from this talk, because it is important for their proliferation at the site of the bone marrow, for their maturation, for their migration into peripheral blood, as well as for their recruitment. And a number of things can lead to eosinophilic activation and interleukin-5 development. So, oops, go back a slide. So viruses and helminths obviously can activate them, pollutants, as well as inhaled allergens. And all of these can activate either at the level of the mast site or the dendritic cell, or innate lymphocyte cell type 2. And the Th2, which is a subtype of CD4 cells, can secrete interleukin-5, which leads to eosinophilic activation. So interleukin-5 is an important factor in the development and proliferation of eosinophils. With regard to lung damage, as well as potentially in cases where they can cause vasculitis, eosinophils migrate into the tissue, and interleukin-5 can actually drive some of this migration. Although there are other receptors, including the CCR3, as well as B cell involvement, as well as T cell involvement, that can lead to migration of eosinophils into tissue. So what is the diagnosis in this case? Oops, go back a slide. It's a tough question, and I actually agree most with Dr. Cable that this most likely represents hypereosinophilic syndrome. And we'll just keep that in your mind for a minute, because if you look at the EGPA 1990 criteria, which still remain, these are the most up-to-date criteria for the diagnosis of EGPA, which is a vasculitis, a small vessel vasculitis, you find that having 4 out of the 6 of these has a 88% sensitivity and a 99% specificity according to studies for EGPA. So, so she didn't really have ground glass opacities, but she did have some nodules. So it's a stretch, but we can maybe give her pulmonary infiltrates. She did have a paranasal sinus abnormality, so we could give her that one. Then we have extravascular eosinophils, most certainly. She didn't have any neuropathic symptoms, and certainly there was no evidence of mononeuritis multiplex. So it's hard to give her this one. She did have peripheral eosinophilia, and there was some bronchial airway changes on her CT of her chest. So she meets a number of criteria by EGPA, but then take a look at how hypereosinophilic syndrome has really been defined. A hypereosinophilic syndrome is defined by the association of hypereosinophilia that's having 1,500 cells in peripheral blood on 2 examinations separated by time, along with eosinophilic mediated organ damage or dysfunction. So, and then there's different subtypes, which Dr. Cable already kind of went over, and Gleick syndrome, which has been associated, one subtype of secondary HES associated with lymphoma variant, has been specifically associated with recurrent angioedema, which she also took some time to mention, but she's right, it's very rare, maybe only about like 50 case reports in the entire literature. So what is the diagnosis here? Honestly, it could be either one. It really could be. And there are a number of experts across the entire country that believe that EGPA is really just a manifestation of hypereosinophilic syndrome. And these 2 disorders exist on an overlap and a continuum. Okay. If one of these lung nodules were to have been biopsied, you might find changes around a vessel here, suggestive of eosinophils, which are shown by the arrowheads, as well as neutrophilic infiltration and plasma cell infiltration, as shown by the big arrow here. EGPA has several different phases, which include the prodromal phase, the eosinophilic phase, and the vasculitic phase. Sometimes before we get to the vasculitic phase, it is possible for patients to just be stuck in the eosinophilic phase. And the providers who saw this patient initially felt that it might have been possible that she was in the eosinophilic phase of EGPA. And certainly what I want you to walk away with, and I'm going to show you a next slide on hypereosinophilic syndrome typical manifestations, but these are the manifestations of EGPA, and you'll find that a lot of them have overlap with hypereosinophilic syndrome. So with EGPA specifically, more than 90% of patients have asthma as a cardinal feature. 70 to 80% develop upper airway disease, sinusitis, polyposis. 50% of patients will develop pulmonary opacities or nodules. And this last point, last but not least, is certainly very important, which is that 15% of patients can end up developing cardiac manifestations. And this accounts for 1/2 of all deaths due to EGPA. And this can be a variety of different manifestations, from valvular insufficiencies to pericardial effusions to heart failure. And one important point to remember, especially as walking away as internists, is that this can be missed a lot of the time, because dyspnea is recurrently keeps getting attributed in these patients to asthma and pulmonary disease. And so it's easy to overlook the cardiac disease. So the 2021 Vasculitis Foundation guidelines actually recommend screening all patients with newly diagnosed EGPA with a pro-BNP, a troponin, as well as an echocardiogram. And as you'll see in the next slide, this specific thing to remember about cardiac manifestations, you should also apply to HES. Although the number here is lower at 5%, it's still a leading cause of mortality in patients with hypereosinophilic syndrome. And as you see in HES, there's a number of different manifestations, but a lot of them share an overlap with EGPA. No vasculitis was also seen on the biopsy that this patient had done. And so that might actually support HES just as much as EGPA in this case, despite the fact that she meets diagnostic criteria. Next, we'll talk briefly about treatment for a few minutes. So the Vasculitis Foundation guidelines break up treatment into active disease, severe disease, and non-severe disease. We'll focus on severe and non-severe disease as we think about these next couple slides. This patient was treated, I think around 2017, 2018, with steroids and azathioprine, which she had an excellent response to in terms of her symptoms. But around that time, mepolizumab, also goes by the brand name Nucala, actually came out and was published in the seminal New England Journal article for the treatment of EGPA. Now, mepolizumab, kind of correlating with pathophysiology here, is an interleukin-5 antagonist. Okay, so again, it would decrease proliferation, maturation, as well as demargination of eosinophils. So, and it works quite well for these patients that had non-severe disease, meaning there was no organ failure, but mild organ involvement in patients with diagnostic criteria meeting EGPA. The mepolizumab improved, led to a remission in about 30% of patients. So a number needed to treat of about 3, which is a pretty good number. And so it's not surprising that when these guidelines actually came out this year in 2021 for the Vasculitis Foundation, they actually recommend that in order of preference for active non-severe EGPA, the first-line treatment could be glucocorticoids with mepolizumab as the treatment of choice. And then you can move on to these other things based on either cost or provider preference or other options. But if you have active severe disease, that means you actually have myocarditis, there is diffuse alveolar hemorrhage or mononeuritis multiplex with a wrist or a foot drop, we would characterize that as severe EGPA, and that most likely needs to be treated with either cyclophosphamide or rituximab. With regards to this, of course, if there's still breakthrough activity, we can add on mepolizumab as well. And there's certainly a lot of data that's been coming out that suggests that that would be helpful. And so I'll end on this final slide, which really shows again that there's quite a bit of overlap between EGPA and hypereosinophilic syndrome, as well as ANCA vasculitis at large. The fact that this patient's ANCA was negative should not necessarily dissuade you completely from EGPA as a potential diagnosis. I think for the reasons outlined of the lack of vasculitis, plus the angioedema and other things, I would likely probably lean towards HES as an overlap with EGPA in this case. But a lot of patients, up to 50% of patients with EGPA can have a negative ANCA. And certainly, these patients are more likely to be overlap patients in the first place, as Dr. Cable described. So that is it. That's the end. Well done, Dr. Cable.
You can call me Casey. Thank you so much for that. Was actually a fantastic review that I've actually stolen some of your references. So thank you so much. And it was interesting as I was going through some of this, looking at the mepolizumab and some of the other treatments for HES. I think that's interesting, the overlap as well, which I think speaks to the fact that this is kind of, this kind of a gray zone between all of these.
The experts agree. So and that's not just me, that's, across the country. So yeah, definitely, probably an overlap. Well done.
Excellent. Thank you all both for volunteering. I appreciate you guys speaking your thoughts and walking us through this educational journey. So thank you all.
Absolutely. I'll hand it back to Dr. Wood for anything else he wants to finish with or questions.
Yeah, I'll pass my baton over to Dr. Bergman currently. Just say thank you to you all for volunteering to go today and be in the hot seat, so to speak, and to all of our those that donated as well to our holiday fundraiser. Fantastic last grand rounds of the year. So thank you all very much. Thank you, VCU.
Thank you all so much. Wow, what a fantastic grand rounds to end the year on. That was really great review all the way from the pathology and expert clinical reasoning. Thank you both. Really appreciate that. So I think I don't see any direct questions. We have maybe 1 or 2 minutes. If anybody has anything, you can raise your hand or use the chat function and we can take maybe 1 or 2 questions. You all do guest appearances at holiday parties, I understand. So just send a tweet to book your time. I think I'm just seeing congratulations in the chat box. Great job to both of you. So I think we'll end it here. This is the end of the VCU Department of Medicine grand rounds. We'll stick around for a few minutes. Just the CME questionnaire and QR code will be up on the screen in a minute. But thanks again to our experts. Thank you, Dr. Cable, for all your wonderful work and preparing for this. I know it's tough. So thank you, Dr. Wood, for organizing and pulling everyone together. Really exciting time. So thank you all so much. The chat room will be open for the CME credits. And if you wish to connect with anyone, thank you all so much. Take care.